When we were students of cardiology, 1980s, aortic stenosis term was very comfortable for us because we thought it is a degenerative disease apart from the neonatal or congenital AS. And it would progress very slowly and it wouldn't excite us because it was going to the surgeons. But then off late, with all the exciting field of TAVR and then the understanding of pathophysiology of aortic stenosis, it is no more a degenerative disease. It is programmed molecular and cellular and enzymes act, and end stage disease only you see as calcific aortic stenosis. So there are several factors: gender difference, the bicuspid aortic, tricuspid aortic valve, and the discordance. Though the echocardiogram, all of us have been believing it is the test modality to identify the severity and to suggest the therapeutic modality, whether the patient should go for aggressive intervention or medical management. But as the literature and as we get the reports, it is variably reported that there is almost 3 to 40% discordance in echocardiographic evaluation of the severity. And we know the cost of missing a severe aortic stenosis because of the low gradient. So all these areas, what data we have, and I'll try to share our data, what we have after going through this. This is all the prevalence, all of us are aware. In India also it is picking up, and I'm sure many more patients will go for the proper evaluation and therapeutic modality if the cost comes down. So this is what excites most of interventional cardiologists. And the risk factors, one thing is like your coronary artery calcium, the aortic valve calcium also, the initiation phase seems to be the same, where there is endothelial injury, then lipoprotein accumulation, T lymphocytes, then oxidized LDL, and then the transition into osteopontin, and then the valvular interstitial cells and endothelial cells, then becoming the resulting in calcium. So lipoprotein A in Asian patients and also in aortic calcification is identified to be one of the causative factors in initiation, but probably not in progression, because the hemodynamic properties calcium begets the calcium. So this is what the female, the women, the gender difference between valve, mitral and aortic valves. And there is some data recently on bicuspid aortic valve calcification. Is there any difference between bicuspid and tricuspid valve calcification pattern? So leaflet tips and then annular calcification is supposed to be more in bicuspid aortic valve, and volume is also more compared to, because of the change or whatever oscillatory shear force of the non-coronary cusp, whatever they talk. And it is more of valvular burden, whereas tricuspid aortic stenosis, which is an elderly age group, it is total aortic valve burden, where there is associated valvular disease or left atrial or arrhythmia, atrial fibrillation. So we have to look at those angles when you especially look for symptoms to allow us to take a decision for the therapeutic modality. We no longer believe that there is a long latent period in every person. There are some people where there is a rapid progression of the disease, and then this is this latent period at which some of us and all of us have to act to pick up the patients who go into incipient LV dysfunction and irreversible failure. So this is where moderate AS is as bad, or at least it is not a very benign condition. We have to be very cautious with this. So this is what shear stress and all, a lot of recent data is coming up, and the traditional approach of echo and this transesophageal echo now resulted in taking up for the new modality, and the CT is the one which is now the modality which is useful. And the other the modalities like PET CT for sodium fluoride or FDG PET for inflammatory activity, either it is coronary calcium or aortic calcium, it still has to find a place, and MRI still non-availability, and its role in identification of or diagnosis and choosing a therapeutic modality. This is how it has evolved. The aortic stenosis, the asymptomatic subset between 4 and 5 or 3.54 or between 5 and 6 is the zone where still there is a lot of confusion how you handle how you take a decision of this. And the indications for aortic valve, I will not go into the details. When patient is symptomatic and severe IS, there is no problem. Only in asymptomatic patients, and then especially in elderly patients where other comorbid conditions are responsible, or patients do not complain of symptoms. So that is a segment which is definitely a gray zone. All of us meet day in and day out during our routine practice. So these are all the subsets, as all of you know, and it is as sir has rightly mentioned, till now there is no clear data on this paradoxical low flow, low gradient, though certain studies have shown, which are non-randomized, and publications with a lot of overlap in symptoms also. So we still are not very sure, but this is entirely a different ball game. These patients do have a different LV remodeling process, wherein the cavity is small, there is relative increase in the wall thickness, and also the aortic impedance is more in these patients. And if most of them have hypertension, and because of that, you get a falsely low gradient. You have to take, that's why you have to measure hypertension, blood pressure whenever you give echocardiographic gradient. So this is how the different subsets all of us are aware. And the current, the calcium score, how the data, longitudinal studies, and all these have shown us. Earlier, there was a big overlap between severe calcific aortic valve, but mild AS. We used to see about maybe 15, 20 years ago. But once it is identified that male-female gender difference is there in aortic calcification, and a threshold is being talked of, now it is gaining importance with regard to diagnosis of aortic valve stenosis severity, and also not only in the diagnosis, but even in the prognostication, aortic valve calcification, when it's its presence in the along with the coronary artery calcification, how it correlates. There is some data in the different percentiles, and also this is the prognosis, some of the subsets in partner trial, and also these are all the arbitrary figures. And we also tried to dig out some of our data, and we have been focusing in the past 10 years on the coronary artery calcium in the past 10 years. But then we took out these patients and then tried to look at aortic velocity in some of these patients whom we have done TAVR. So some of these people had, see, this is 752, this is a disparity, the female, where mean pressure gradient was 103 millimeters. So likewise, there was some parity, 730 when there was 54 aortic velocity mean pressure gradient. So this is our patient data, and we are trying to dig out more and more and see how we can measure and then follow these patients of aortic sclerosis of the volume which we have in echocardiographic evaluation. And this is all we are trying to make some data. It is unpublished, but we are collecting the data. So definitely it is an exciting topic, the aortic valve stenosis, the calcification, how it helps us in picking up the right patient at the right time, especially these subsets of patients where the gradient is less, but still aortic valve area is small, and then taking other various other factors which are responsible for this. So these are all the things. And now with regard to CT, the measurement of aortic valve calcification, we have to be cautious. You can't take the data of prospective gating, which we usually do in coronary artery CTCA, because we do it in diastole. But in multiphasic evaluation, if you do both in systole and diastole, you may have a more comprehensive data on this aortic calcification. There is some methodology how to do it. And once you know that calcium, it's a dynamic process, biologically active, probably the studies what you have, the statins and the ASS and OPS, they are probably done in the delayed phase, late phase of the disease. So if you do the studies, interventional studies at the younger age, especially aortic sclerotic patients or bicuspid aortic valve patients, probably it may yield some result in prevention and also postponing the disease. So yeah, this is lipoproteinuria and South Asian ethnicity. So the number of patients undergoing isolated aortic valve replacement, it nearly tripled, and hemodynamic evaluation has numerous potential measurement errors. Aortic valve replacement decisions have historically been based on symptoms. Patients evaluated the present era are older and less likely to have symptoms or comorbid conditions. Integration of all clinical data with attention to hemodynamic measurements detail is essential to identify patients who will benefit from aortic valve replacement. It's a multi-step disorder leading to the heart failure, endothelial dysfunction, followed by lipid deposition and inflammation. It triggers this aortic valve disease. Myofibroblastic differentiation of valvular interstitial cells causes AV fibrosis. Dystrophic calcification and biomineralization result in mechanically incompetent AV. Lipid-lowering drugs, ACEs, ARBs, then cytokine inhibitors may be tested like denosumab in future. And measurement of aortic valve calcification is useful in assessing aortic stenosis severity in patients for whom echocardiography is not conclusive. Aortic valve calcification should be measured on non-contrast, and sometimes even in contrast, you can have fibrocalcific assessment, especially in females. Calcification of the left ventricular aorta, you have to be cautious in measuring mitral annulus, LVOT, then right coronary ostium, and anything. This is the data. Arbitrary 2000 and odd and 1300 is the calcium score which is given to have some assessment when in a confusing case.